My interest in this topic started actually a little bit, obviously, when I was in my medical training, but I think it became something I became more interested in when I was at McKinsey Company, because I spent both my time in the corporate risk practice, which was mostly working for banks doing credit risk modeling, but also in the healthcare sector. And one of the first questions I had when I showed up was, I hear that we spend a lot of money on healthcare in the United States, but I have no idea how or why or where. So I was like, hey, does anybody have a P&L for this system? And the answer was always like, no, not really. It doesn't work that way. It's kind of complicated. And it was like, huh. Right off the bat, that's sort of a bad sign. Like when you're spending nearly $3 trillion on something and it's not clear where the money's going, or if it is, but you're not really, it becomes problematic. But rest assured, we've resolved that. So I'm going to share with you what that looks like. That said, this is a super complicated topic. It's certainly no less complicated than the last topic we got into. And the last topic, as you could tell, we only scratched the surface of. So we're certainly only taking not a 30,000-foot view, but what I'd probably call sort of a 130,000-foot view of this problem. So let's just start with the sort of obligatory fact set. So this is a country that's enjoyed an amazing increase in economic prosperity over the past 60 years or 50 years, as evidenced by the green line. But unfortunately, during that same period of time, our spending on healthcare has increased at a far greater rate. So that means that our spending on healthcare as a share of our economic wealth has grown disproportionately. I hope you will accept on face value my assertion that that is not sustainable indefinitely. So how does it actually look? Well, these are actually dated numbers. This is 2009. Unfortunately, the number is worth today. But one way to slice this problem up is to ask, how much money do we spend per person on healthcare? And of course, you want to do this against your OECD peers. I mean, it's not particularly interesting when we compare ourselves to Liberia. But it should be interesting to compare ourselves to Australia, Japan, the UK, Canada, et cetera. And so even amongst our economic peers, we spend significantly more money per person than them. And by the way, today the number is actually about $9,000 per person per year. That's a pretty big increase, but you have to remember, these data are artificially low because what was going on in 2009? Right, the worst recession since the Depression. And so we actually saw healthcare spending stall during that period of time, but now it's back in full force. So what do we get for all that money? Look, at the end of the day, the problem with most healthcare discussions and debates is they're really all about black and white, and I'm going to try to dispel some of that today. But you should never really just argue that the cost of something is too great without weighing out the cost benefit of it, right? And so what do we get for our cost? Would it be worth spending $9,000 per person per year on healthcare if nobody ever got sick and if everybody got health coverage? And I think most of us would say, yeah, it would be. But what do we get? Well, we get 48 million Americans who are uninsured, 60 million Americans that don't have a usual source of care. And by the way, where do those people go for their care? Yeah, what does that do to healthcare costs? Yeah. And what percentage of Americans delay or avoid treatment due to the cost? 32 million. And what does that do to long-term care? Drives up the cost. So at the surface, we're certainly not getting a lot of bang for our buck. Furthermore, and this is the part that really kind of just drove me absolutely crazy once I started to understand the system, the cost of healthcare is a shell game. It's basically, you have more price transparency at the Lebanese carpet store than you do with, you talked about getting the bill for $500,000 being in the hospital for a month. I can assure you that if you lived, if everything else was the same and you lived in a different state, that bill would have looked different. Now, I get that cherries should cost more in one state than another because you have to ship the cherry, this far versus that far. But it's very hard for me to explain this discrepancy. So what this graph is showing you is the top line is basically the average initial bill for the most expensive inpatient procedure by state, and the blue shows you what the Medicare reimbursement is. In other words, Medicare has basically said, we're just paying a flat fee. We don't really care where you are. But the hospitals are still playing this game of, well, we're going to charge different things to different people, and we'll make it up for it on different ends. And so what you don't even see in here, because it becomes so complicated, is that payers will reimburse at different rates. So by the way, the person who gets screwed the hardest is the self-pay. Right? You have no negotiating power whatsoever. So if you want to pay cash for a procedure, you want to go and have a major operation, I mean, you are the favorite patient of a hospital. Unbelievable how much money is made on a cash patient. And it's a subsidy. You have to subsidize. So you could argue Medicaid is paying, of course, below Medicare. They might actually be losing money on those things. So you have a multi-tiered system of payment. All right. So because we're going to focus on healthcare, I think it's worth putting it in perspective. I remember during an election, and again, I don't want to make this political because this is actually not about one party versus another. But I remember during a recent election, I think it was the 2008 election, I was talking with somebody about, well, what are your thoughts about McCain versus Obama? And the person was saying that they favored McCain, which again, I don't think that's right or wrong one way or the other, but their argument was what made me think of this story. Their argument was his position on stem cell research. No, it was on like abortion or something like that. And I said, look, I don't particularly care to have that discussion, but I'm not sure, if you remember what was going on in November of 2008, like when we were literally about to implode our economy, it was sort of like, I'm not sure we have the luxury of caring about abortion at this moment relative to some of the other things that matter. So I'd want to believe that we're picking our politicians more based on their ability to avoid icebergs than their ability to serve surf and turf versus casserole on the Titanic, right? Like so what I would argue is there are a handful of economic icebergs that are potentially catastrophic. And so what are they? So there are probably three things, and it's really a great exercise to look at the United States budget, right? Meaning like, what is the budget of this country? People talk about the deficit. Oh, the deficit's a horrible problem, blah, blah, blah. Okay, great. What are we spending money on? These are the three things. You know the 80-20 principle, right? Like the 80-20 principle at its finest is, what are the things we really spend money on? It's healthcare, it's entitlement, and it's defense. So let's look at what's happening with each of those. So not only is healthcare the largest, but the point is its rate of increase is the largest. When your first and second derivative are both the largest for one problem, that's the problem I'd worry about the most. So while I do think entitlement issues are important and need to be resolved, while I do think pension overhead is an enormous problem that will be catastrophic, to many places it already is, Detroit, Chicago, there's a lot of places that are already in a heap of trouble. When you think about the total calamity of this nationally, I'm having a hard time seeing a problem on the horizon that is closer to us than the healthcare spending problem. Okay, so why is this problem so hard to solve? This problem, I would argue, is very hard to solve because most people don't understand the process of optimization. Now, admittedly, I'm biased because I'm an engineer, and engineers love optimization problems. We live in a world of local and minimal mins and maxes and this, that, and the other thing. But it's hard to do that on a sort of personal level. But let's try. So this is just my framework. So I'm not a sophisticated healthcare economist or anything like that. So I'm sure there are far more sophisticated systems. But my view is that there are basically three axes along which we should consider optimization. The first is access, right? In an ideal world, if you were starting from first principles, I think we would want to have a healthcare system where the greatest majority of people had access to care. Okay. The second is quality. If you were designing a system from first principles, I think you would want to provide the best quality care imaginable. It's not enough if everyone has access to the system if the system sucks or the healthcare you get is suboptimal. Finally, I think the third axis here is one of cost. If you can provide the best access in the world and you can provide the best quality in the world, but the cost is $1 million per person per year, it doesn't make sense. So how can you optimize around cost, access, and quality? Now, this is probably how we stack up today. I think it's safe to say that in the United States, our access is reasonable but not great, and certainly nowhere near that of our OECD peers. In other words, if you live in Canada or in the UK or in Australia, you probably have more, on average, you have more access to healthcare, not at the individual level. In the United States, as you know, it's highly disparate. There are many people who have virtually no access to healthcare, and there are people who have the most remarkable access to healthcare. But on average, we're not that great on the axis. I think the United States is, on average, the highest in quality, and probably, and that's debatable. What's probably not debatable is at the individual level. At the individual level, if you can buy it, you get the best healthcare in this country. And look, I don't remember the last time I met somebody who went over to Europe for their healthcare when they were a billionaire. But they all come here. When you've got an obscure diagnosis, you're coming to the United States. So certainly at the pinnacle, the United States has the best quality of healthcare. It's debatable on average if it's the best. You could argue that there are other countries that do a better job. Certainly they do dollar per dollar, but it's not clear in the absolute. But on the cost axis, as I think I've already demonstrated to you, we are amongst the worst of our peers. We are the worst by a country mile amongst our peers. Okay, so that's the situation today, and it appears nobody's happy about it. Otherwise, we wouldn't be having this discussion. Okay, so this is how we think about the problem. We look at this and we say, we're not happy. We want this. Now, nobody shows you this graph when they say it, but you've heard the rhetoric, right? Like you've seen the political discussion. That's basically what they're saying. We have this, it's not good. Must have this. Okay. I'm here to tell you that's metaphysically impossible. You can't, I don't think you can do this. I don't think you can reduce the cost by 50%, increase the access, and dramatically increase the quality. I could be wrong. I think the closest you can, and I won't tell you where I think we can or can't get. I have feelings about which of these levers you have more to go with. But I will say that until you at least think about it through this lens, we're pretty much going to get nowhere. So this is where it's got us. So lots of talk, lots of rhetoric, lots of political BS, but no one's really having the sort of, what I think is the sort of critical discussion around what are the trade-offs we're willing to make. For example, would we be willing to spend just as much as we're spending now without increasing it if we could increase quality and access? That's a discussion that probably is worth having. Are we willing to reduce the cost without reducing quality or access? That's a question. So, all right. So today I want to focus on kind of what I sort of think of as two bookends of this problem. The patient interaction, which is at one end of the spectrum, and then the other one is kind of the structural problem. And I'll just tell you right now, I'm going to spend probably a little bit more time on the structural problem because I actually think that's the more interesting problem. I think the patient interaction, I will share with you a couple of stories that I think are critical for physicians and as healthcare providers. I think I share these as anecdotes to help you think about how you deliver care, because at the end of the day, the structure, the metastructure is sort of what allows the system to function, but technically healthcare is really mostly about an interaction between a provider and a patient. That's the interaction that governs most people's perception of healthcare, but what most people don't see is the payer and the provider relationship and the payer and the patient relationship and all these other things. But and that's unique, I think, to all countries. What is really interesting, and again, the part I really want to talk about, is the structural thing, because that's kind of unique to the US problem. And by the way, I will argue that the current structural problem prohibits change, meaningful change. So the structure has to be fixed, and if we can do that, I think we've got a shot at this. But let's get to the part that I think is maybe more interesting and enlightening, which is the structural side of the US healthcare system. All right. Now, it's funny. It took me a long time to truly understand how the system worked. It's because it really is a black box, right? So it's a $2.8 trillion black box, meaning $2.8 trillion flows into and out of this system. So the first thing you have to understand is what's putting the money in, what's taking the money out. So basically the money goes in from 4 sources. The government. The government puts money in through 2 programs. Medicare, which is a program for the elderly, and Medicaid, which is a program for the poor. Private payers. What's a payer? A payer is your insurance company. Now the private payer, so I distinguished private from government payer. The government is acting as a payer. CMS, Center for Medicaid and Medicare Services, is a payer. But the private is like your Blue Cross, your Blue Shield, your Anthem, United, Aetna, all those folks. Now, they don't always pay your health insurance. As I'll discuss in a few minutes, we have 2 different types of healthcare. We have 2 different types of insurance through a payer. Sometimes your employer is actually paying the cost, and the insurance company is just administering a service, and sometimes the actual risk is carried by the payer. So the thing to always ask your question about is who bears the risk? So if you are 70 years old, the government carries your risk. If you get sick, the government is paying. If you are poor, the government is carrying your risk if you qualify for Medicaid. If you are uninsured, you carry your risk. You are your own payer. If you are at a small company, your payer carries the risk. Because at a small company, the employer can't afford to cover the risk. So they're just paying into a pool, and the insurance company manages the risk. If you're at a large employer, your employer actually carries the risk. So if you work at Google, Google is actually carrying the risk. Even though your health insurance card says United, United doesn't carry any risk. They're just making a few dollars off you, sort of like a Visa card does. If you get sick, your employer is going to pay for it. Okay, so those are basically the 4 buckets that go into it. And then where does the money go? It goes to hospitals. It goes to providers specifically, so physicians that contract directly, so this is both inpatient and outpatient. It goes to pharma companies, medical device companies, DRE, so durable medical stuff. It goes to diagnostic tests, and it goes to labs. All right, this is the single most important 2 graphs of my life, which is what is the sources and uses of cash? Remember when I said, can somebody please show me the P&L of the US healthcare system? This is basically it. 41.7% of the money that enters that black box comes from the government. Medicare, Medicaid, and other sources of public funding. 38.2% of that comes from private insurance, which includes both the government, both the payer and the employer. We don't distinguish those here. So basically, it's 40-40, and then about 11% comes from consumer out-of-pocket, and 8.6 comes from a bunch of other small programs. Where does the money go? You guys are on here. Look, dental care, 4%. The money goes, about 70% of it goes to, you can see hospital care being the single largest, physician office and other professional services, okay? And then on the pharma side, you've got, and by the way, inpatient pharma is included in hospital. That's what makes these data so complicated to tease out. So medical device and inpatient pharma are lumped in the greens. Then you have outpatient pharma, outpatient medical device making up 13%. And then you have the actual cost of administering all this is 7%. And think about that, 7% of 2.8 trillion. You see why people get pissed about administration costs? That's a big cost. So let's revisit the problem statement. So I've just explained to you how $2.8 trillion enters the healthcare system, how $2.8 trillion exits the healthcare system. Let's revisit the problem statement. Today we are spending $9,000 per person per year in the United States on healthcare. We should just assert a goal. Right? We can't keep spending this much money. So what if we want to reduce that to, say, $5,000 per person per year to be in line with our peers? What would have to happen? Well, we'd have to put less money in and take less money out. Okay, this is where it gets interesting. How do other countries manage to keep their healthcare costs as low as they do? Why is Canada spending so much less than us? Why is the UK spending so much less than us? What's the fundamental difference? There's a more fundamental difference. All of those things are true. The fundamental difference is the structure of the system. In all countries but ours, for the most part, healthcare is budget driven. What that means is the federal government sets a budget at the beginning of the year that says, this is how much we are spending on healthcare. Now, is that a perfect system? It is not. And I'll share with you what that looks like in a system where it goes wrong, right? So in Canada, I remember, because I was still living there at the time, they basically said, look, we're capping salaries on physicians. We're capping, and it was done by specialty. I mean, there was nuance to it. Obviously, a cardiac surgeon is going to make more than an internist. But the point is, if you were a urologist living in Toronto, I have no idea what the cap was, but it was X dollars. When you build the Canadian insurance, the Ontario insurance system for those dollars, the moment you hit that, you couldn't make another dollar. So what kind of incentive does that provide? Well, I'll tell you what it meant. It meant a lot of docs worked 8 months a year, and by September, nobody was working anymore because you'd already hit your cap. You could make your cap in 8 months, and then you didn't work. So that's an extreme example of a budget-driven system. The United States is the exact opposite of that. It is a 100% demand-driven system. Think push versus pull. In the United States, it's the output that's driving the input, not the reverse. So every other country says we're fixing the input, output is what it is. The US says no, we're not going to fix anything. Let the output be what the output is, and the input will match to it. So two ends of the spectrum. I'm going to assert that neither is perfect, but the one we're in is devastating. Case in point, look at what we're doing. So what drives demand? So if we've established that it's a demand-driven system, then we need to know what's driving demand. Demand is driven primarily by two entities, the hospital and the provider. And remember, that's reflected in our P&L, which is how many of those dollars are actually being driven hospital providers. So what does that mean? Well, this is where it gets to some of the comments that have been made, right? More patients going through the system. Sicker patients going through the system, higher DRGs. So remember, I mean, and I say this, look, I'd say this openly if we were sitting with a bunch of hospital administrators. At the end of the day, hospitals make money the sicker you are, right? I mean, I talk with my friends who are, busily building clinical practices, and at the end of the day, their compensation is based on the DRG, the diagnosis-related group. The sicker your patient is, the more money you get paid. So, for example, a cardiac surgeon who's operating on somebody who's got a more complicated case than another person is going to get paid more. And that makes sense, right? I mean, you're taking a bigger risk. It's usually a harder person to take care of. But the point remains that our system is compensating us based on the sickness of the patient. Patients are staying longer in the hospitals. Procedures are being done more frequently. Unfortunately, there are a lot of unnecessary procedures. We'll talk a little bit about that. I think that is a problem that is very unique to the United States. And it's a political hot button, but I'm going to address it anyway. So if the answer is less sickness, less time in the hospital, fewer unnecessary procedures, you'd want to believe that somewhere in here there's a mechanism to compensate physicians or providers to avoid illness. And we all talk about that. That gets a lot of lip service. Has anybody ever heard of wellness programs? Right. Not particularly effective, are they? And they're not effective because they're not compensated effectively, right? So at the end of the day, the dollars drive the behavior. So when you don't pay a physician to inform their patient about, look, if you gave me an hour a week with a patient, I'm positive, and I don't just mean me because I'm anything special. I mean, if you gave a doctor who knew what they were talking about with respect to nutrition and all these other things, an hour per week with a patient for 6 months, could you fix their life? I think you could fix many people. I think you could actually generate an amazing ROI on that when you consider what you could save down the line. But it can't be done. The healthcare system will not compensate that, right? A physician has typically 6 to 10 minutes with a patient, and during that period of time, the imperative thing is to capture and record all of their DRGs and create a specific treatment plan. So again, problem number one, think demand-driven. Problem number two, think compensation is based on illness, not avoiding illness. This is a sensitive topic for people, especially my brother who's a lawyer, but I think my brother actually can't disagree with me on this. We have a tort problem in the United States. And it's very hard to study this technically. Meaning, so the opponents of the tort argument will say the following, and they're correct. When you compare healthcare costs in Texas with those in Pennsylvania, we do not see a significant difference. Why did I use those two states? Basically, you can put all US states into one of three categories, A, B, or C. A are very, very favorable tort conditions for litigators, lawyers, and patients. B is intermediate states, and C are states that are highly favorable to the doctor and the hospital. Texas is a C state. Very favorable, very hard to sue your doctor or hospital in Texas. Pennsylvania, Nevada are the opposite. Michigan, I mean, if your doctor looks at you wrong, you could probably get $1 million out of them. California is a B state. We're kind of in the middle. And it is true that at the surface, the difference in cost between an A state and a C state is relatively minor. I would argue, and I push back and say that actually that's because you can't capture, you're measuring the wrong thing. You're simply measuring the cost of litigation. That's the tip of the iceberg. That's not what is actually driving the cost. I asserted that back here. Nowhere on this list is litigation. What is on this list is procedures. And the question is, how many of those procedures are unnecessary? Now look, I realized this the day I started my residency, which was, how many things did we do to patients, how many tests did we order that were completely unnecessary, but we explicitly did because we wanted to avoid litigation down the line? Do anyone want to hazard a guess how many head CTs I ordered in people that I knew just had caffeine withdrawal? But what choice did I have? Because think about it this way. If I order the head CT on this guy, and it's going to be negative, I've covered myself because the statute of limitations on that is like, I don't want to have to ever think about it again. I don't want to have to worry that in 4 years I get served a subpoena because I missed an aneurysm in a guy 4 years ago. I'm not paying for the CT scan. I realize, and believe me, we would sit around and argue about this all day long because you felt like you were doing something wrong. You felt like you were just flushing money down the toilet, ordering all of these goofy, unnecessary tests that had no bearing. They exposed patients to unnecessary risk, unnecessary radiation, enormous cost to the system. But you did it because I wasn't getting radiated more. I wasn't going to have to pay for it, but I got to walk away and never have to think about it again. And so study after study has found that 20 to 30% of the tests and procedures that are done on patients are deemed unnecessary by physicians, but are done purely for defensive reasons. Again, I don't know if this is something that applies in your field or not. If it is, it'd be an interesting lunchtime discussion. But I believe that the culture of tort in the United States is unlike anything I've ever seen. So let's get to the key. Who's paying for this? So we've asserted what the government's doing. The government is paying. Today and tomorrow, the burden of this is being increasingly shifted to the employer. So again, let me reiterate how ASOs work and risk. In the payer landscape, if you look at the profit and loss statement or the income statement for pick Aetna or United or WellPoint, the biggest payers in the world, in the United States, they basically make money on two products. One is called ASO, one is called risk. ASO stands for Administrative Service Only. That's the service where large employers are bearing the risk, but they're transferring the administrative portion of that to the payer. So the ASO business is a low margin, high volume business. You sort of make about 7% margin on that, but you take no risk. The risk business is where the payer takes the risk. So because my employer is small, it certainly could never afford to take the risk. You know, in a company of 10 people, if one person gets sick, it would wipe out the entire company. So, you know, think about it. A $500,000 hospital bill could destroy a 10-person company, right? So the actual risk is borne by the payer. We are seeing a shift to more and more employers carrying the risk. That's driven largely by the following. The employer believes it can better manage the cost. So when you are doing an ASO, you get no pricing. You get no pricing control with the payer. So if you are United and I am Joe Schmo Company, and I come to you and I say, I've got 50 employees, I'd like them insured, you just tell me the price. I don't have any say, I just have to pay you that amount. You've baked in, obviously, a reasonable enough margin that you're not going to lose money because you're the expert on this. You're the actuary. You know how you'll make 5 to 6% on that, guaranteed. And that price keeps going up and up and up because the cost of providing health care is going up and up and up. So I'm not here to tell you that payers are evil. I think that's a really popular knee-jerk thing to say. The payers are evil. They're not actually evil. I'll tell you this, the margin made by your healthcare company is less than State Farm and Allstate, right? No, I don't see anybody saying that how much we hate State Farm for how much money they make insuring our cars or our houses. So what drives the premium is the service. So the payer's not responsible for the service. I hate my payer because they nickel and dime me over my prescription or whatever. But let's be clear on what they're doing that's driving us nuts versus not. They're not setting the price. They're simply an intermediary. And the employer is saying, wait a minute. If I'm paying this guy and every year it's going up 6%, and I have no say in that, and he controls the guy that's getting sick, I want, as the employer, to now manage that risk because I think I'll do a better job getting my employers to be healthier. And so that's where the employers are coming in. So we are seeing a risk transfer. We're seeing a transfer of risk from the employer, from the payer to the employer. So we are seeing a trend towards more and more of the ASO. So the only thing you really want to remember from all this is in tomorrow's world, you should think of employers and payers as basically the same. There are two things that have to happen for the US healthcare system to be fixed. And I would argue most people are fixated on number two, which I think is necessary but not sufficient. And most people never want to talk about number one because it's really politically incorrect. Step one is we must have a philosophical change about who carries the risk. Today, the risk is almost exclusively carried by the payer, meaning the employer, the insurance company, the government. Tomorrow, if we have any chance of fixing this system, we have to transfer that risk to the hospital and the provider and the patient. That trio must carry the lion's share of the risk somehow. The second step, which does get a lot of traction, but unfortunately at the exclusion of the former, is we need a new set of tools to compare and contrast. Because if you are going to pass on the risk to the patient, they must be able to do what this gentleman probably did last month when he bought his car, which is make rational decisions about trade-offs of features. Think about it. I mean, my wife calls me an e-shopaholic because I'm always, I hate going to stores. So anything I buy, I'm buying online. And so if I'm buying it online, why not do a comparison? I'm just obsessed with comparing stuff. Even if I'm buying underwear, I kind of want to know if Calvin Klein or American Apparel is better. Let's find out. And so we can do this for anything. We can compare anything we buy. We can find out how much does it cost? What are the features? What are the trade-offs? What's the upside? What's the downside? And yet, the one thing we spend more money on as a society than anything else, and I can say that without hyperbole, we spend more money on healthcare than anything else. We have no insight into what it cost, why it cost, what the economic trade-off is. So until we fix those two problems, unfortunately, I think we're screwed. The good news is, being screwed, I think, forces you to reconsider things. And it is my sincere hope that in time, as the water gets a little warmer, people will start to revisit these uncomfortable questions about what is it we're optimizing for in healthcare? Is it access? Is it quality? Is it cost? And in what proportions? And how do we fix it?